Welcome to our discussion on the impact of methicillin-resistant Staphylococcus aureus nasal screening in lower respiratory tract infections. We'll explore findings from a systematic review incorporating network and Bayesian meta-analyses. Methicillin-resistant Staphylococcus aureus pneumonia presents a significant clinical challenge, with mortality rates up to 30% in community-acquired cases and 55% in hospital-acquired pneumonia or ventilator-associated pneumonia. Despite its rarity, causing less than 1% of community-acquired and 20 to 40% of nosocomial pneumonias, empirical vancomycin is standard, risking unnecessary antimicrobial exposure and increased costs. Methicillin-resistant Staphylococcus aureus nasal polymerase chain reaction revolutionizes diagnostics with rapid results, delivering outcomes in hours compared to traditional cultures. It boasts a 95% to 99% negative predictive value, effectively ruling out methicillin-resistant Staphylococcus aureus pneumonia. Endorsed by the Infectious Diseases Society of America in both 2019 and 2024 guidelines, it is recommended for patients with methicillin-resistant Staphylococcus aureus risk factors. We aim to systematically evaluate methicillin-resistant Staphylococcus aureus nasal screening strategies in hospitalized patients with suspected or confirmed lower respiratory tract infections. The primary outcome is the duration of methicillin-resistant Staphylococcus aureus targeted therapy. Secondary outcomes include vancomycin trough monitoring, length of stay, acute kidney injury, in-hospital mortality, and 30-day readmission. Our analytic approach involves frequentist, network, and Bayesian meta-analyses. Our methods include a comprehensive meta-analysis, data extraction, study selection, and literature search. We focused on adult inpatients with conditions like community-acquired pneumonia, hospital-acquired pneumonia, ventilator-associated pneumonia, healthcare-associated pneumonia, aspiration pneumonia, or chronic obstructive pulmonary disease exacerbation, who underwent methicillin-resistant Staphylococcus aureus nasal or oropharyngeal screening via polymerase chain reaction or culture. Our study population includes 15 studies with 2,872 total patients, screened from 149 reports. The median study size is 156 patients. Notably, 71% of these studies have been published since 2020, all based in the United States. Half of the studies are from community hospitals, with the rest in academic or tertiary settings. The primary result shows that PDP plus PCR reduces the duration of methicillin-resistant Staphylococcus aureus therapy by 1.34 days compared to the standard of care. Network meta-analysis confirms PDP plus PCR is most effective, with a 1.51-day reduction. Polymerase chain reaction or culture alone offer no significant benefit. Bayesian analysis indicates a 99% probability of exceeding the 0.65-day minimum clinically important difference threshold. Pharmacist-driven protocols are essential for success. Vancomycin trough monitoring shows a 79% reduction in odds, with an odds ratio of 0.21. Acute kidney injury odds reduced by 46%, with an odds ratio of 0.54. In-hospital mortality decreased by 30%, especially in intensive care unit patients. No significant difference in 30-day readmission or hospital length of stay. Bayesian analysis evaluates the probability of treatment effects surpassing clinically meaningful thresholds. For methicillin-resistant Staphylococcus aureus therapy duration, there's a 100% probability of exceeding the minimal clinically important difference. Trough monitoring shows a 99% probability of meaningful reduction. However, for acute kidney injury, mortality, and readmission, the probability of exceeding minimal clinically important difference is 36% or less. The network meta-analysis highlights that polymerase chain reaction testing alone is inadequate. The combination of rapid diagnostics and pharmacist-led stewardship is crucial. Negative polymerase chain reaction results enable swift methicillin-resistant Staphylococcus aureus negative identification, triggering pharmacist protocols for de-escalation. This leads to vancomycin discontinuation, reducing nephrotoxic exposure, especially in high-risk intensive care unit patients, and improving outcomes like reduced acute kidney injury, mortality, and monitoring burden. Economic implications reveal significant cost savings per patient. Meng et al. Report a median cost avoidance of 40.33, while Huffman et al. Show savings of 23.61 per patient. Inflation-adjusted savings range from $29 to $50. Further comprehensive economic modeling is necessary to include nursing time and environmental costs. Methicillin-resistant Staphylococcus aureus nasal polymerase chain reaction screening, combined with pharmacist-driven protocols, reduces methicillin-resistant Staphylococcus aureus therapy exposure and improves outcomes in lower respiratory tract infection patients. All United States hospitals should integrate these protocols. Safety is confirmed, with no increase in readmissions or mortality. Future research should focus on pediatric populations, linezolid-specific analyses, and health economic modeling.